Good afternoon, everyone, and thank you for joining this test case presentation entitled Use of Real-World Evidence to Characterize Patients with Uncontrolled Hypertension. My name is Keondae Ervin, and I am a Senior Project Manager of Research at the NEST Coordinating Center, and I will be moderating this session. Before we get started, I would like to introduce the following panel participants for this session. We have Dr. Naomi Aronson, who is the Executive Director of Clinical Evaluation, Innovation, and Policy at the Blue Cross Blue Shield Association. We have Dr. Barrette, who is the Senior Director of Global Health Economics and Outcomes Research at Medtronic. We have Dr. Yuan, who is an Assistant Professor at the Yale School of Medicine. We have Dr. Joseph Ross, who is a Professor of Medicine and Public Health at the Yale School of Medicine. We have Dr. Meir, who is a Medical Officer of Circulatory Support Devices within the OHT2, OPEQ, CDRH division of the FDA, and Dr. Douglas Silverstein, who is a Medical Officer of Renal and Transplantation Devices within the OHT3, OPEQ, CDRH division of the FDA. Next slide. This study was a feasibility study that had a project duration of roughly 12 months. This test case sought to characterize patients with uncontrolled hypertension using electronic health records with the intent of generating evidence to develop guidelines for coverage decision of medical devices and to gather clinical data for electrode renal denervation systems, to which the TPLC, or total product life cycle, of this study is in the pre-market phase with a potential PMA regulatory pathway. Next slide. When reviewing this study for test case selection, there were a specific set of criteria met to align with NEST's data quality and methodological rigor for conducting real-world evidence studies. This study used retrospective real-world health system data to identify patients with uncontrolled hypertension while also understanding medication treatment patterns, clinical characteristics, and demographic information. The study also was able to evaluate both short and long-term clinical outcomes for the selected cohort of patients. Another important criterion in the selection of this test case is the ability to gather electronic medical record data from multiple large health systems, which have the potential to be a rich data source to better understand the targeted patient population. This test case has an inherent value to the medical device ecosystem and NEST by providing important and quality evidence on hypertension management in real-world settings and an avenue to implement quality improvement measures. Knowing that patients with hypertension are at an increased risk for stroke, heart attack, heart failure, and kidney failure, it is important to also understand that hypertension can carry a significant economic and clinical burden to patients, families, and communities that hypertension affects. The role of NEST in this study was comprised of providing clear and timely guidance, as well as feedback when necessary throughout the life cycle of the project, which included navigating any challenges that may have arisen. Stakeholder management was also pivotal to this study to ensure that data partners and the sponsor organization were in alignment to ensure all needs were being met. And now I'd like to hand it off to Dr. Barrette and Dr. Liu.
Thanks. So I'll give a brief introduction to the technology and the test case, and Dr. Liu will then present on the study design and the results. Next slide, please. I just want to say first, thank you to all of the collaborators, the NEST team, my Medtronic colleagues, and especially the Yale New Haven Health System and One Florida teams who worked extremely hard to design and conduct this study. Next slide, please. Briefly, the technology of interest for this test case is the Simplicity Spiral Renal Denervation System. This is a multi-electrode renal denervation system that includes a catheter and a generator. And the idea is that it helps regulate blood pressure for patients with uncontrolled hypertension. It's a minimally invasive catheter-based therapy, delivering energy to the nerves leading to the kidneys. There's multiple ongoing clinical trials currently. There's a multi-phase clinical strategy designed to isolate and demonstrate the safety and effectiveness of this procedure for patients with uncontrolled hypertension. Two trials in particular, the Spiral on-med and Spiral off-med pivotal trials, are prospectively powered, randomized sham-controlled trials. There's also a Simplicity registry collecting real-world data on patients outside the United States. And we believe this test case will provide additional evidence to the body of evidence supporting renal denervation. Next slide, please. The idea of the test case was to use health system data to retrospectively identify patients with hypertension and help us better understand their demographic and clinical characteristics, medication treatment patterns, and clinical outcomes from real-world data sources. The objective was to assess the feasibility of using EHR data from Yale New Haven Health System and the One Florida Clinical Research Consortium to identify and characterize patient populations, both with controlled and uncontrolled hypertension. The anticipated application is across the total product life cycle. So from this test case, we're hoping to first develop evidence on hypertension management in a real-world setting. Second, provide data to help establish a reliable benchmark for payers to understand the potential scope of the target population for RDN. And third, understand how to evaluate RDN's impact on patient outcomes using real-world data once the therapy is approved by the US FDA and on the market. At this point, I'll hand it over to Dr. Liu to present the study design and results.
Thank you, Eric. So let me just give you a little bit background of the test case. Can we go to the next slide? As you're aware, this study is not a typical intervention study, yet it still has many added values. First of all, the study will provide meaningful evidence in evaluation of uncontrolled hypertension, which is a disease, if we untreated, will pose significant economic and clinical burden to the patient. In the context of COVID-19 pandemic, the Surgeon General Office in the last year just released a call for action to make hypertension control as a national priority. Longitudinal data from the electronic health record is an important element in real-world data evidence. This study will provide a comprehensive feasibility assessment of longitudinal EHR data across two large health systems. And the result of this study will also provide invocation to develop coverage decisions for a specified device. And this is an important value to NEST and align with the next mission to enhance clinical research with the patient-centered focus. Lastly, the study will also highlight ability to characterize a diverse target adult population in two clinical research networks, including the Yale New Haven Health System and the One Florida Clinical Research Consortium. We must be aware that the study does not include any regulatory intention, but rather is trying to better understand disease prevalence and control to inform clinical efforts and potential market for the device and technology for blood pressure control. Next slide, please. This study is a retrospective cohort analysis, as we mentioned. We use an observational study design, and there is no direct intervention for the patient. There are two participating sites, including the Yale New Haven Health System and One Florida. And we use EHR data all mapped to the ProCornet Common Data Model version 5.1. These will allow us to execute the query and study code consistently across two different sites. We have several study milestones. In AIM-1, we develop operational definition of controlled and uncontrolled hypertension using EHR data. And using this definition, we identify and characterize patients with controlled and uncontrolled hypertension. In AIM-2, we assess medication prescription pattern, which include the number and class of medication among patients with uncontrolled and controlled hypertension. Lastly, we explore the feasibility for using EHR data to look at short-term outcome at 3 and 6 months and long-term outcome at 12 and 24 months. to look at the clinical outcome and hospital care utilization among this patient with uncontrolled and controlled hypertension. Next slide. Now let's look a little bit more in detail for the study population. We're interested in adult patient, which is age 18 years and older with regular outpatient care. We define regular outpatient care as those with at least 2 outpatient encounters from the 2 large health systems between October 1st, 2015 and December 31st, 2018. We use October 2015 as a starting point because at that time, the health system started to use ICD-10 code. Our target population include patients with hypertension, which is defined as population meeting at least one of these following criteria. The first criteria is that if they have an ICD-10 code of hypertension in any of the hospital admission, ED visits, or outpatient visits. And the second condition is that if they don't have a hypertension diagnosis, then they would need to have at least 2 elevated blood pressure measurements, defined as systolic blood pressure greater than 140 or diastolic blood pressure greater or equal than 90 in the EHR in 2 separate outpatient visits, at least 1 day apart within a period of 6 months. We have several exclusion criteria. We exclude patients with no blood pressure measurement at least 3 months after the identification and between October 1st, 2016 and December 31st, 2018. We use this criteria to allow us to have 1 year look-back period for the medication prescription and at least 1 year follow-up period for the outcome. We also exclude female patients who are pregnant and patients receiving dialysis during the study period. Finally, we exclude blood pressure measurement only from the inpatient and ED visits. Next slide, please. To generate robust estimates, we apply 3 different approaches to define controlled and uncontrolled hypertension. In the first approach, we use a blood pressure measurement randomly selected between October 2016 and December 2018, and use that blood pressure measurement to define controlled versus uncontrolled hypertension. The rationale for using a randomly selected blood pressure measurement is that there may be many blood pressure measurements for a given patient, and if we always select the earliest blood pressure measurement, we would bias the sample to younger patients and will have fewer experience for adverse event, or vice versa if we always select the current or most recent encounter. So we use a blood pressure selected at random to ensure objective and systematic cohort identification. Approach 1 is focused on 1 blood pressure measurement. And approach 2, we look at a range of blood pressure measurement and look at if 50% or greater of the blood pressure measurements are above the control target, then we consider as uncontrolled. And vice versa, if 50% of the blood pressure measurement or more are below the control target, then it's considered as controlled hypertension. Approach 3 is very similar to approach 2, where we look at a range of blood pressure measurement, but now we have a stricter criteria compared to approach 2. We use 75% of the blood pressure measurement below the control cutoff to define controlled hypertension. And finally, we do the Meir analysis using 140 and 90 as the blood pressure cutoff to be consistent with the EHR data we extracted from. And we also conducted a sensitivity analysis using 130 and 80 as the cutoff to be consistent with the most recent 2017 AHA hypertension guidelines. Next slide, please. On this slide, we show the overlaps between all 3 different approaches. We look at overlaps in the population between approach, which is defined as patients who have the same hypertension status. They're either controlled or uncontrolled between 2 different approaches. As you see on this table, the majority of the patients identified are overlapping between 3 different approaches. For example, between approach 1 and approach 2, the overlap is 86.8% in the one Florida data set, and 86.4% in the Yale data set. And when we look at this pairwise comparison, we found the overlap between approach 2 and 3 is the greatest. It reached about 90% in both data sets. So therefore, we focus on approach 1 and approach 2 in the subsequent analysis. Next slide, please. In AIM2, when we look at medication prescription pattern, we need to classify a prescription order into hypertensive indication and also into different antihypertensive drug classes. We use a previous developed classification system based on IX query, and we include only oral formulation for hypertensive indication. Specifically, we classify antihypertensive medication into several drug classes, including the ACE inhibitor, angiotensin receptor blockers, beta blockers, calcium channel blockers, or diuretics, and other antihypertensive drugs. For combination drugs, we classify them into multiple classes of combination drugs. Next slide, please. In AIM3, we look at different outcomes as an exploratory analysis. Specifically, we look at short-term outcome at 3 and 6 months, and long-term outcome at 12 and 24 months. For the clinical outcome, we include death, which is identified through a combination of death record, death diagnosis, and encounters with an expired discharge status. We also look at non-fatal CVD events, which include acute myocardial infarction, different kinds of stroke, heart failure, atrial fibrillation, aortic dissection, renal disease, and hypertensive crisis. Finally, we assess healthcare utilization by looking at ED visit, hospital admission for any causes, and also outpatient visits for any causes. Next slide, please. Now let's look at the results together. This table shows you the result for AIM1, which is the characteristic of the population. As you can see here, for one Florida site, the percentage of uncontrolled hypertension is about 40%. And for the Yale site, the percentage on uncontrolled hypertension is about 1/3. So we know that uncontrolled hypertension is quite common across these two large health systems. Now we look at different characteristics associated with uncontrolled hypertension. The age and gender distribution looks quite similar between controlled versus uncontrolled hypertension. Now we look at the race distribution. We found that African American are disproportionately affected by uncontrolled hypertension. The percentage is higher among Blacks, and also among those people with obesity. Another thing we notice when we look at the result is that the patient with uncontrolled hypertension has fewer comorbidities. We need to be noted that this is a descriptive analysis. There may be multiple reasons for why uncontrolled hypertension patients have fewer comorbidities. Maybe because those with more comorbidities, they are more likely to seek healthcare, more likely to be in contact with healthcare provider, therefore more likely to be have controlled hypertension. Next slide, please. In AIM2, we look at the prescription pattern. And when we look at prescription for different drug classes for uncontrolled and controlled hypertension. Look at this table. If we look at the last row, we can see that more than 50% of the patient with controlled and uncontrolled hypertension, they have no prescription for antihypertensive medication. So this implies a large opportunity for improvement. And maybe also because we include patients without diagnosis of hypertension, but have elevated blood pressure in our study population. These patients don't have diagnosis, therefore they may not have prescription for antihypertensive treatment. And among those with antihypertensive treatment, ACE or ARB seems to be the most common drug class prescribed in both data sets, followed by calcium channel blockers and beta blocker. Combination drug class single pill combination therapy, as you notice in the second last row, is only prescribed in about 5% of the patient across different database. One thing we need to notice is that this data represent prescription pattern, but does not indicate any compliance with the medication among patients. Next slide, please. In M3, when we look at the outcomes, we look at both long-term and short-term outcome. Here in the table, we show the outcome at 3 months and 12 months. The event rate, to our surprise, is quite similar between control and uncontrolled hypertension subgroups. The difference is not statistically or clinically meaningful, maybe because the time duration we look at is quite short. Even for 24 months, it's still not long enough to distinguish the outcome between the two groups. And again, this is just simple descriptive analysis. We have not adjusted for any patient characteristic. So just the accrual rate, we show that the outcome events are quite similar between the two groups. Next slide, please. After we do all these analysis, a few lessons learned from this test case. As we expected, we feel that the EHR data are is quite complex. Using this data to understand real-world problem is challenging. The whole team put together substantial efforts to ensure alignment of methods and similarity in outcomes between the two data sources. Specifically, in this test case, we developed 3 operational definitions for control versus uncontrolled hypertension to improve the robustness of the results. Fortunately, we found that our results are quite consistent across the 2 different approaches, or the 3 different approaches. Second, this project demonstrates need for stakeholder alignment in application of real-world evidence throughout the total product life cycle because of these potential challenges in defining and identifying a population that is specific to a condition. Finally, this study is just a start. It's just a descriptive analysis, but it lays an important foundation for more sophisticated analysis to look at the quality and outcome associated with the care for this patient in the future projects. Thank you so much for attention. So next I will transfer to Dr. Shinnar for more of the FDA perspective.
Hi, I'm Meir, cardiologist in the device section of the FDA. Next slide, please. The application of real-world evidence to regulatory issues is important for the FDA. The benefits are the broader, more diverse population as well as practitioners, and it reflects actual practice. There are limitations in terms of the lack of standardized definitions and the accuracy of the data, missing data, lack of education, and bias. Next slide. So there is an FDA guidance document about the use of real-world evidence to support regulatory decision-making for medical devices. Next slide. So this protocol is an epidemiological study of prevalence of a condition. Therefore, it's not really under FDA purview, as no intervention was studied, and normally we would not be reviewing it except if it's offered in support of another application. Next slide. As the purpose is to establish prevalence of a condition that's a target of a new device, we have to look at the study definitions, which is some last or 50% more than 140/90. Next slide. So the question is this study really congruent with a normal understanding of uncontrolled hypertension? And can we rely on the data in the chart? Next slide. So the AHA guidelines recognize that blood pressure is very highly variable. The technique of measuring it is quite complex. And even with the currently elevated blood pressures, they may not reflect to hypertension. And therefore, blood pressure in the chart may not always be enough to define hypertension. Next slide. And this is from the guidelines. Because individual blood pressure measurements are unpredictable, a single measurement is inadequate, and at least 2 or 3 measurements or 2 to 3 operations are necessary. Next slide. Also from the guidelines, that even if you measure hypertension and it's consistent, it is still reasonable to screen for the presence of white coat hypertension using daytime ambulatory blood pressure measurement or home blood pressure measurement. Next slide. And this is a description of the measurement technique. And by empiric evidence, I think for most of us, this is not as widely employed as it should be because of the amount of time that it takes to employ. Next slide. So therefore, the question is the data reliable? So on one level is they enter the data properly in the chart. There's always some error, but that's not a major problem. But there is a question, was the blood pressure measured properly in the clinic so it actually reflects what is necessary for intervention? And is the data enough to identify the hypertension, to account for the variability of the blood pressure, and that even if you get recurrently measured, properly measured, elevated blood pressure, it may still not be true hypertension. Next slide. And so therefore, for intervention, and we would typically like that the blood pressure is repeatedly greater than the target, proper technique is employed, and as well that there isn't a consideration that this may merely be white coat hypertension. This, of course, makes the real-world evidence is quite difficult a problem to solve. Next slide. And now I'd like to hand it over to Dr. Aronson.
Thank you, Dr. Shinnar. This was a very interesting study. As Dr. Shinnar points out, it's an epidemiologic study. It's descriptive, but it's quite informative. And how can we use the results of this study? I think it suggests a population that might benefit from such treatment, but it doesn't demonstrate a population that would benefit for such treatment. The real value would be, does it provide a hypothesis that can be tested? Can one analyze the effects of using renal denervation in this population? And that would be informative. There will be a great deal of interest if such time that this device comes to approval and availability in the market. There will be great interest as to who would be the appropriate candidate. Certainly, payers will be reluctant to cover very broadly. They will have reservations. They will really want to know that there is a targeted population. Studies such as we have just seen could, if applied in a hypothesis generating mode, help us to answer those questions. And with that, I will welcome questions from our audience.